Hello everyone. Today we'll discuss hyponatremia, one of the most common electrolyte disorders encountered in clinical practice. Hyponatremia is defined as a serum sodium concentration less than 135 MEq per liter. Remember that normal serum sodium ranges from 135 to 145 MEq per liter. Therefore, any value below 135 is considered hyponatremia. Hyponatremia is very common, especially in hospitalized patients. It occurs in up to 30% of hospitalized patients, making it an important condition that every physician should recognize and manage appropriately. Classification of hyponatremia. We classify hyponatremia in two ways. 1. Based on the severity. Mild hyponatremia. Serum sodium 130 to 134 MEq per liter. Moderate hyponatremia. Serum sodium 120 to 129 MEq per liter. Severe hyponatremia. Serum sodium less than 120 MEq per liter. 2. Based on time of development. This classification is very important because it determines how quickly we can correct the sodium level. Acute hyponatremia. Develops within less than 48 hours. Chronic hyponatremia. Present for 48 hours or more. In chronic cases, if we do not know how long the patient has had hyponatremia, we should consider it chronic until proven otherwise. This approach helps prevent overly rapid correction and reduces the risk of osmotic demyelination. Now that we've learned how to classify hyponatremia, let's move on to its causes. One of the most useful investigations is the urinary sodium concentration, because it helps us identify whether the kidneys are appropriately conserving sodium or inappropriately losing it. We divide the causes according to urinary sodium. There are two main categories. Urinary sodium more than 20 mmol per liter. Urinary sodium less than 20 mmol per liter. 1. Urinary sodium more than 20 mmol per liter. This means the kidneys are losing sodium into the urine, despite the patient being hyponatremic. In other words, the kidneys are either the cause of sodium loss or are unable to conserve sodium properly. There are two situations. A. Sodium depletion, renal sodium loss. The patient is usually hypovolemic because both sodium and water are being lost. Common causes include diuretics, especially thiazide diuretics, which are the most common drug-induced cause of hyponatremia. These drugs increase sodium excretion, leading to volume depletion and low serum sodium. Diuretic stage of renal failure. During the recovery phase of acute kidney injury, the kidneys produce large amounts of urine but cannot effectively reabsorb sodium. As a result, sodium is lost in the urine. Addison's disease. In primary adrenal insufficiency, there is aldosterone deficiency. Normally, aldosterone promotes sodium reabsorption in the distal nephron. Without aldosterone, sodium is lost in urine. Water follows sodium. The patient becomes hypovolemic and hyponatremic. B. Patient often euvolemic. These patients have normal extracellular fluid volume, but excess free water dilutes serum sodium. The two classic causes are SIADH, syndrome of inappropriate antidiuretic hormone secretion. This is one of the most common causes of euvolemic hyponatremia. Excess ADH causes excessive water reabsorption. Water retention dilutes serum sodium, while sodium excretion continues normally. The slide also mentions urine osmolality more than 500 mmol per kilogram. This indicates that the kidneys are producing concentrated urine, despite the presence of hyponatremia. Normally, urine should be dilute when sodium is low. Hypothyroidism. Hypothyroidism can reduce cardiac output and impair free water clearance, resulting in water retention and dilutional hyponatremia. 2. Urinary sodium less than 20 mmol per liter. Here, the kidneys are appropriately conserving sodium. A low urinary sodium suggests that sodium loss is occurring outside the kidneys, or that the body is retaining water. Again, there are two groups. A. Sodium depletion, extrarenal sodium loss. The patient is usually hypovolemic. The kidneys respond correctly by conserving sodium, so urinary sodium becomes less than 20 mmol per liter. Examples include diarrhea. Large amounts of sodium and water are lost through the gastrointestinal tract. Vomiting. Although gastric fluid contains relatively little sodium, prolonged vomiting causes volume depletion and eventually hyponatremia. Sweating. Excessive sweating leads to sodium and water loss. If only water is replaced, hyponatremia develops. Burns. Burn patients lose sodium-rich fluid through damaged skin. Villus adenoma of the rectum. These tumors produce large amounts of sodium-rich mucus, leading to chronic sodium depletion. B. Water excess. These patients are usually hypervolemic and often have edema. The problem is too much water, rather than sodium loss. Common causes include secondary hyperaldosteronism, seen in conditions causing reduced effective circulating volume. Examples include heart failure, liver cirrhosis. Although total body sodium increases, total body water increases even more, producing dilutional hyponatremia. Reduced GFR, renal failure. The kidneys cannot excrete free water effectively. Water accumulates and dilutes serum sodium. IV dextrose. Administration of large volumes of hypotonic fluids such as dextrose solutions can dilute serum sodium. Psychogenic polydipsia. Patients drink excessive amounts of water. The kidneys cannot excrete the excess water rapidly enough, leading to dilutional hyponatremia. Now we'll discuss the diagnostic algorithm for hyponatremia. This flowchart summarizes the step-by-step approach that every clinician should follow when evaluating a patient with a serum sodium below 135 MEq per liter. Step 1. Confirm hyponatremia. We start with the definition. Serum sodium less than 135 mmol per liter. Once hyponatremia is confirmed, don't jump immediately to the cause. The first investigation is to measure the plasma osmolality, because not every patient with low sodium has true hypotonic hyponatremia. Step 2. Measure plasma osmolality. There are three possibilities. A. Isotonic hyponatremia. Plasma osmolality equals 280 to 295 mosm per kilogram. This is called pseudo-hyponatremia. Here, sodium appears low on laboratory testing, but plasma tonicity is actually normal. It occurs in patients with severe hyperlipidemia, severe hyperproteinemia, e.g., multiple myeloma. These substances interfere with some laboratory measurement techniques, producing a falsely low sodium level. Key point: the patient does not have true hypoosmolar hyponatremia. B. Hypotonic hyponatremia. Plasma osmolality less than 280 mosm per kilogram. This is true hyponatremia and represents the majority of clinical cases. C. Hypertonic hyponatremia. Plasma osmolality more than 295 mosm per kilogram. Here, plasma is actually hyperosmolar. Common causes include hyperglycemia. High blood glucose pulls water out of cells into the extracellular space. This dilutes serum sodium, causing dilutional hyponatremia. Hypertonic administration. Examples include mannitol. Hypertonic contrast agents. These osmotic agents shift water into the extracellular space, lowering the measured sodium concentration. Step 3. Assess volume status. For patients with hypotonic hyponatremia, determine whether they are hypovolemic, euvolemic, hypervolemic. This is the most important clinical step. A hypovolemic hyponatremia. These patients have loss of both sodium and water, but sodium loss is greater. Clinical signs include dry mucous membranes, hypotension, tachycardia, poor skin turgor. Next, measure urinary sodium. Urine sodium more than 20 mmol per liter. The kidneys are losing sodium. This indicates renal sodium loss. Examples include diuretics, Addison's disease, salt-wasting nephropathies. Urine sodium less than 20 mmol per liter. The kidneys are conserving sodium appropriately. Therefore, sodium loss is occurring outside the kidneys. Examples include diarrhea, vomiting, sweating, burns. B. Euvolemic hyponatremia. These patients appear clinically normal. They have no edema, no dehydration. Urinary sodium is usually more than 20 mmol per liter. The most common causes are SIADH. Excess ADH causes water retention, resulting in dilutional hyponatremia. Endocrinopathies. Always exclude endocrine disorders before diagnosing SIADH. Examples include glucocorticoid deficiency, adrenal insufficiency. Hypothyroidism, although not shown clearly in this figure, it is also an important cause. Potassium depletion. The flowchart also reminds us that potassium depletion, diuretic use, can contribute to hyponatremia and should always be considered during evaluation. C. Hypervolemic hyponatremia. These patients have increased total body water and sodium, but water retention exceeds sodium retention, leading to edema. Examples include peripheral edema, ascites, pulmonary edema. Again, urinary sodium helps determine the cause. Urine sodium more than 20 mmol per liter. The kidneys are unable to retain sodium. The classic cause is renal failure. Damaged kidneys cannot appropriately conserve sodium. Urine sodium less than 20 mmol per liter. The kidneys are functioning appropriately and are trying to conserve sodium. Think of edematous disorders such as heart failure, liver cirrhosis, nephrotic syndrome. These conditions reduce the effective arterial blood volume, stimulating ADH and aldosterone, which promote water retention and dilutional hyponatremia. After understanding the causes and diagnosis of hyponatremia, let's discuss how patients present clinically and what investigations we should request. Clinical features, symptoms and signs. The symptoms of hyponatremia mainly result from water moving into brain cells, causing cerebral edema. The severity of symptoms depends on how low the sodium level is, and how quickly it falls. Acute hyponatremia usually causes more severe symptoms than chronic hyponatremia because the brain has not yet adapted. 1. Fatigue and muscle weakness. These are among the earliest and most common symptoms. Low sodium affects neuromuscular function, so patients often complain of generalized fatigue, low energy, muscle weakness, difficulty performing daily activities. These symptoms are usually seen in mild to moderate hyponatremia. 2. Gait disturbance and falls. Hyponatremia impairs balance, coordination, attention. As a result, patients, especially the elderly, may develop unsteady gait, difficulty walking, recurrent falls. Clinical pearl. Even mild chronic hyponatremia significantly increases the risk of falls and fractures in older adults. 3. Cerebral edema. This is the most serious complication. Because plasma becomes hypotonic, water moves into brain cells, leading to brain swelling. Neurological manifestations include headache, confusion, disorientation, drowsiness, seizures, coma in severe cases. These findings are medical emergencies and require prompt treatment. Investigations. Once hyponatremia is confirmed, we investigate the underlying cause. 1. Spot random urinary sodium and urine osmolality. This is one of the most important investigations. We measure urinary sodium. It helps determine whether sodium loss is renal urine sodium more than 20 mmol per liter, extra-renal urine sodium less than 20 mmol per liter. Urine osmolality. This tells us whether ADH is active. High urine osmolality tells us that ADH is present, e.g., SIADH. Low urine osmolality tells us that there is excess water intake, such as psychogenic polydipsia. Important note: urinary sodium may be misleading in renal impairment or during diuretic therapy. This is an important exam point. For example, diuretics increase urinary sodium artificially. Renal failure impairs the kidneys' ability to regulate sodium. Therefore, Urinary sodium should always be interpreted in the clinical context. 2. Look for evidence of thiazide diuretic abuse. Thiazide diuretics are one of the most common causes of hyponatremia. Patients taking thiazides may have several characteristic laboratory abnormalities such as hypokalemia, hyponatremia, hypochloremia, metabolic alkalosis, hypomagnesemia, hypercalcemia. Unlike loop diuretics, thiazides increase calcium reabsorption, so serum calcium may be elevated. Hyperuricemia. Volume depletion reduces uric acid excretion, increasing serum uric acid levels. This explains why thiazides may precipitate gout. Hyperglycemia. Thiazides may impair glucose tolerance, leading to elevated blood glucose levels. After diagnosing the type and cause of hyponatremia, the next step is management. Treatment depends on 3 important factors: the patient's volume status, hypovolemic, euvolemic, or hypervolemic; the duration, acute or chronic; whether the patient has severe neurological symptoms. The most important principle is, treat the underlying cause and avoid correcting sodium too rapidly. 1. Hypovolemic hyponatremia. These patients have lost both sodium and water, but sodium loss is greater. A high blood urea supports the diagnosis of dehydration and volume depletion. Treatment. The treatment is rehydration with 0.9% sodium chloride, normal saline. Normal saline restores intravascular volume. Sodium deficit. As volume improves, ADH secretion decreases, allowing the kidneys to excrete excess water and correct the hyponatremia. Important warning: do not correct sodium too quickly. Aim for 10 MEq per liter or less increase in serum sodium per day. Rapid correction, especially in chronic hyponatremia, can cause central pontine myelinolysis, now called osmotic demyelination syndrome. This serious neurological complication results from rapid water movement out of brain cells, causing destruction of the myelin sheath. Clinical manifestations include dysarthria, dysphagia, quadriplegia, locked-in syndrome. Remember, correct slowly, especially if the hyponatremia is chronic. 2. Euvolemic hyponatremia. The most common cause is SIADH. In SIADH, there is excessive ADH secretion, leading to water retention without significant sodium retention. Treatment. First, treat the underlying cause whenever possible. For example, stop offending medications. Treat pneumonia or CNS disease. Correct hypothyroidism or adrenal insufficiency if present. If SIAD persists, fluid restriction. This is the first-line treatment. Limiting water intake reduces dilution of serum sodium. Demeclocycline, an older drug that induces nephrogenic diabetes insipidus, reducing the kidney's response to ADH. It is used less frequently today because of potential nephrotoxicity. Tolvaptan, a vasopressin V2 receptor antagonist. It blocks the action of ADH, promoting free water excretion without increasing sodium loss. It is particularly useful in selected patients with SIAD. 3. Hypervolemic hyponatremia. These patients have too much total body water, leading to edema and dilutional hyponatremia. Treatment. Treat the underlying disease. Examples: improve cardiac function in heart failure. Manage cirrhosis. Treat nephrotic syndrome. In addition, fluid restriction limits further water retention. Salt restriction reduces fluid accumulation. Diuretics, especially loop diuretics, which help remove excess sodium and water. 4. Acute, less than 48 hours or symptomatic hyponatremia. This is a medical emergency. Patients may present with seizures, coma, respiratory arrest, severe headache, nausea, vomiting, tremors, confusion, abnormal movements. These symptoms indicate cerebral edema. Emergency treatment. 3% hypertonic saline. Give 100 ml bolus of 3% hypertonic saline. If symptoms persist, Repeat up to 2 additional 100 ml boluses. Maximum 300 ml over approximately 30 minutes. The goal is not to normalize sodium immediately. The immediate goal is simply to reduce brain swelling and stop seizures. Goal of sodium correction. The correction target depends on the patient's symptoms. A. Severe hyponatremia with mild or no symptoms. Serum sodium less than 120 mEq per liter. Target. Increase serum sodium by 4 to 6 mEq per liter during the first 24 hours. Maximum safe correction. 8 mEq per liter in 24 hours. This minimizes the risk of osmotic demyelination syndrome. B. Severe symptoms, seizures or coma. The immediate goal is increase serum sodium by 4 to 6 mEq per liter within the first 6 hours. This small increase is usually enough to reduce cerebral edema and improve neurological symptoms. After that, correction should slow down to avoid overcorrection.